Mark Cotter is one of the world's leading researchers in cervical spondylotic myelopathy. We've come here to Addenbrooke's Hospital to find out a bit more about the condition. We're here with Mark Cotter, a researcher at the University of Cambridge and a neurosurgeon at Addenbrooke's Hospital, and we're going to talk about CSM. Hi Mark, you're looking at surgical treatment of the condition, so could you tell us about the surgery please, how it works?
So I'm involved in sort of developing new treatments, non-surgical treatments, but also I'm a neurosurgeon, so I do treat patients with surgery. And I think now the dispute surrounding surgery and the role of surgery in CSM has settled. I think we now very much know that is able to stop disease progression, which is really important in a progressive disease. A large cohort study led by Dr. Fehlings in Canada showed that patients do get benefits from surgery. So there is an inherent capacity of the spinal cord to regenerate itself to a certain extent after surgery.
And what's the basis of that regeneration, please?
That's a very good question, and we found that nobody has answered that. So we conducted an experiment to see, and what we found is that it's mainly driven by axons that are damaged during the compressive phase of the disease, but which have a tendency to regrow once you decompress the cervical spinal cord. And it is possible that other factors such as a repair program mediated by a stem cell population in the brain called oligodendrocyte precursors also contribute to the repair process. However, we need to have a look at this in more detail before we can make any real claims. So the surgery essentially wants to create space around the spinal cord. So you can either go in from behind and take away some of the bony elements at the back, or you could come from the front and remove the discs. And that's what we've done in his case. So in here, this is an image that we took during surgery, and you can see his vertebral bodies here. And as you may imagine, we've removed the disc between the two vertebral bodies and replaced them with an artificial implant, which is a kind of spacer to maintain the alignment between the two vertebral bodies.
We're here at the University of Cambridge Computer Laboratory for the Patient and Public Involvement Day for CSM, where we were talking to some of the patients about their condition.
First thing really was the sensation in my hands. I had very, very strong pins and needles in my fingers, and I thought, well, this is weird, but you know, you put that down to nothing. And then I noticed that my feet were starting to have the same thing, and then increasingly going numb, and then that led to the walking difficulties. With my gait became very stilted, and issues with balance. And at that point I kind of thought, well, there's something really not right here, so better go and have that looked at.
So you went to the GP first, did you?
Yeah, initially went to my GP, and to be fair, he really didn't know. He hadn't got a clue what was wrong with me, but he was on the ball rather, and sent me straight away to have an MRI done. And at that point, I was terrified that this was the beginnings of MS or motor neuron disease or something along that ilk. And to be quite honest, I was very relieved when I was told I had a thing called cervical myelopathy. I'd never heard of it. At that time, although I was numb, I mean, I wasn't ill. It wasn't really affecting my life that much. And I thought, oh, well, thank goodness for that. It's nothing serious. I don't think anyone appreciated how quickly this can degenerate. Nobody told me, and it wasn't really until it got quite significantly worse and I started looking for information, mainly online, that I realised, oh, I'm in for something a bit more serious than I thought.
And that is that when you contacted the neurosurgeons, because you had surgery for this, didn't you?
Well, my GP, after the MRI results came in, I had a referral to a neurosurgeon, and while he did recommend surgery for me, this was 2012, and I was quite frankly very afraid. I was terrified of the thought of spinal surgery. I don't know anyone who wouldn't be. And I kind of thought, well, no, I mean, I'm okay, I'm walking, you know, I'm you know, okay, my hands are a bit funny and my feet are a bit funny, but, you know, I'm okay. And I just kind of put it off. I put it on the back burner, I put it on to the back of my mind and sort of said, no, I'm just going to get on with my life, you know, I'm not going down that route. I didn't really admit to myself how afraid of the surgery I was. So I think it was only, I had a couple of falls and I thought, no, hang on, this is getting significantly worse.
That was affecting your quality of life by that
and
point.
then I started having to walk with the cane, and I thought, no, I've got to get on with this now. I'm still pre-op. I've got 2 to 3 weeks now before I go into hospital, and although I am nervous, I'm a lot better informed now. I've got good support from our online group of friends.
Tell us a bit about the symptoms, please. Do they vary from patient to patient?
So I do find that there's quite a variability between patients. There's some symptoms that are relatively consistent, which make us think that the patient suffers from myelopathy. So most of the patients will have numb or clumsy hands, problems with their gait, hyperreflexia. There's often an element of pain as well, and weakness in the arms or legs. But I've seen patients with a cervical problem mainly presenting with leg issues, whilst the majority will present with symptoms in the upper limb, but also the lower limbs. We don't quite understand it yet, but it's probably because of the anatomy of the spinal cord in the neck. It's a conduit of information between your brain and it connects the rest of your body. And all information that goes to your arms or comes from your arms or to the legs or it comes from your legs needs to pass through the cervical spinal cord. So in theory, it could affect any of those components. It also can affect your breathing. In terms of pain, again, it depends a bit. Some patients get pain because there's also compression of one of the nerves that exits the spinal cord, whereas other patients get what's called more neuropathic pain, which is pain that's caused by damage of the spinal cord, and that can follow a very different pattern. It's often a burning type of pain, which is quite difficult to treat.
And that must make the condition hard to diagnose as well.
Yeah, I think it's the variability of the symptoms, and often because the onset is quite subtle, and these patients are often very good at dealing with the mild symptoms, and they are able to compensate for some of the things that occur for a long time.
And does it take a long time then for some patients to arrive at a diagnosis?
So yes, much too long. So we looked at that. We interrogated about 850 patients in Cambridge using web-based interviews, and we found that in about 30% of the patients, the diagnosis takes more than 5 years, which is not good if you consider that CSM is a progressive disease in most cases.
So ideally you want to shorten the length of time for diagnosis so that you can begin to treat.
Exactly. At least I think you need to be aware at the earliest time point, and then so that you then, together with the patient, can decide what the best time point for surgery is. Some of the patients have very mild symptoms, and maybe that's not the right time point to operate, because the operation itself has risks, of course, as well.
I was told in 2014 that no more could be done for me. The initial symptoms of the tingling in my left arm were resolved. Fabulous, that was great. But in the meantime, I was still left with difficulties with pain, fatigue, numbness in my legs, numbness in my feet, radiculopathy down the right arm as well. So although I don't regret having the operation, because it's actually stopped me from becoming more paralysed, and if you didn't have it you would become more paralysed. I don't regret it, but they couldn't, because I had damage to the spinal cord already as evidenced on the MRI scan. They couldn't restore full function, and when I was actually finally told, that was absolutely devastating to me.
And do
really
you know
devastating.
What the surgery was that they carried out?
Yes, it's called an ACDF, and I'll explain what that means. It's an anterior cervical discectomy with fusion and fixation, and I had it at the C6, C7 level.
And how long an operation was that?
It's about 2.5 hours on the table, and as I understand it, they keep your head in a clamp as well, because I ended up with some bumps on my head where they'd screwed my head to the table.
And so the doctors cared for you, then you were sent home, and how did it progress from there?
And obviously you get your stitches out after a week, and
Yeah.
they tell you be as active as you can.
And then you think your disease has continued to progress despite that surgery?
Well, obviously I don't think it's got any better. At the time of the surgery it was no better, no worse, but certainly this year, in fact, to be honest, from last year as well, probably January last year, I've started to have trouble with breathing, upper back pains coming into more play. I'm definitely getting more symptoms, new symptoms of radiculopathy down the left arm, which are over and above what I was left with at the time of the operation. So personally, yes, I think I'm getting worse.
And you're taking pain medication?
Yeah, I must admit I don't take very much, to be honest, because I tend to take over-the-counter medication, which I get for myself, because I'm not going to go to the GP and waste their time asking for things like paracetamol and ibuprofen when you can just pick it up for pennies. I have been offered things like gabapentin, which are much stronger, but for me it's really difficult because I'm a lone parent, I need to keep my wits about me. I'm the only person in my family that drives, and obviously with the restrictions on what you can take when you're driving now, because that enforcement came into play maybe, I think it's about a year ago now.
Okay,
You've got to be really careful. So I'd rather take minor painkillers to help with things like stiffness, which it sort of works, sometimes doesn't. It doesn't take away the radiculopathy pain, it doesn't take away the mobility difficulties, it doesn't take away the fatigue anyway.
And do you find that your symptoms are the same every day, or are they quite variable?
Overall, I'm the same every day, but my symptoms can actually vary minute to minute, hour to hour as well along the day. There may be times when I've got maybe an hour where I don't feel too bad in the morning, and then suddenly it's like all the energy's drained out of me, the batteries are flat and I have to go to bed, usually triggered by pain. Or if I've not paced myself properly, I have to go to bed, and there's times I'm sleeping 3-4 hours during the day just so I can gather up enough energy to do the school run again and start the evening meal and do the things that need to be done. And I don't sleep well at night, which doesn't help.
Discomfort in bed?
Yeah, I go to bed in pain, I wake up in pain, I get up in the morning in pain. It's constant.
How on earth can it be then that this disease is so under-recognised? I wonder how it can be such a such a common disease and people just don't know about it.
Well, that surprised me, because initially when I developed this I thought, right, okay, Google it, and what can I find? All I could find was that it's a disease of the over 55s, and so it's a consequence of ageing. Well, I was 44 at the time. So I felt, well, that can't be right. That doesn't apply to me. And also, the only other reference to it that I could find it was cervical myelopathy in dogs.
What are the challenges of raising awareness of this condition?
So I think one of the big challenges is that spondylotic myelopathy is quite a mouthful. So simplifying the name of the disease would be helpful. And also, it's a group of diseases because you can actually look into what structural changes cause the disease in terms of changes of your spine. So that includes OPLL, and it includes spondylosis. It could be a disc prolapse, a soft disc prolapse, thickening of ligaments behind the spinal cord. And I think this variety of causes is another problem in terms of unifying the disease under one umbrella. There's been efforts to create a new term for it called degenerative cervical myelopathy, but I do still think that's quite a mouthful as well. And the other thing that we tried to find out is where the gaps in curricula of medical students, GPs, A&E specialists, and we found that although all of the curricula include the disease, it's often a very, very small proportion of their curriculum, and other diseases that are much less frequent seem to cover a much wider space. So we'll have to change the way or the importance of CSM on the curricula.
You held a patient day recently for patients with CSM. Could you tell us a bit about what the assessments were, please?
The point of the patient day was to bring patients suffering from CSM together and learn from them, but also help them to understand the disease better. So we gave them a platform where they could interact amongst them, but also with us. And one of the things that we did is try and understand better how CSM affects their lives. So we looked at what symptoms they reported and what domains of well-being were affected. Another important thing was to understand their needs based on their symptoms and the problems they reported. We also used this CSM Day to create awareness about the disease, but also about what's going on in the disease. So we wanted to bring them up to speed with respect to novel developments in the field, and also very simple facts that may be known amongst the clinicians, but not so well known amongst the patients yet. And finally, we also invited them to participate and feedback on some of the activities that we are doing here in Cambridge, which includes preparations of the first regenerative medicine trial in CSM. So we asked them about the study schedule, the outline, the assessments. We wanted to make sure that we don't miss any important points from their perspective. And we also showcase some of the outcome measures that we're trying to develop using mobile sensors, so sensors in your smartphone or sensors in a smartwatch or even wearable sensors. And so we had some stations where they underwent a gait assessment. So we had video cameras recording the gait, and there was a pressure sensor mat on the floor, which would enable us to capture some of the gait parameters as well. And at the same time, they were using our mobile app, trying to track gait parameters using the sensors that are included in the mobile apps. And we got some very valuable feedback here again. The mobile apps also measure hand function, so like typing speed and accuracy, or tapping speed, and tremor. They also have built-in pop-ups asking disease-specific questions like what's your pain score at this point? Mm-hmm. At the moment we're still looking through the data, but it looks like some of the parameters that we capture really match very well the clinical scores that we normally use in research settings. So that's very exciting.
So you're keeping a sort of constant track of those patients rather than just coming into the clinic once every 6 months to
Exactly.
discuss how things are progressing.
I think that's really why we're so keen to develop those tools, because the healthcare system can't afford constant monitoring of patients. You can't bring them to clinic every week, even though you potentially want to, because you know that the disease is progressive and you want to capture the phase where the symptoms start to accelerate. And so our hope is that some of these outcome measures and tools that you can just upload onto your smartphone or smartwatch will enable us to identify any changes and then potentially schedule a clinic appointment. Or even if we can just have a look at the data at the scheduled appointments, I think it'll be very helpful, as opposed to the snips of data or the impression that we get within a short routine clinical appointment.
I think it must have also been helpful to bring the patients together so that they can discuss their symptoms among a group setting.
We received real great feedback. They were delighted to be able to share their symptoms, and you could see how eager they were to do so, and what sort of level of discussion was triggered by just bringing them all together. And I think that's a really important thing, because speaking to the patients, also those that I meet in my clinical practice, is that there's really no support. There's very little information out there, and what they really require is some information, someone to talk to. And this is one big reason why we're very keen that what started off as a webpage, Myelopathy.org, is going to develop into a charity which fosters support groups and interaction between patients, but also hopes to raise awareness and hopefully promote research in the area of CSM.
So you're hoping to provide a forum for the patients and their carers, I assume, to share stories or discuss what things that can help certain symptoms.
I think that's right. I think the lack of awareness and knowledge means that these patients and their carers feel very isolated. If you compare that to other diseases such as Parkinson's or MS, you've got a fantastic network of help and information, whereas in CSM that's missing. And therefore we're really quite grateful to Accelerate Cambridge, which is a entrepreneurial program in the Judge Business School, which will help us to set up Myelopathy.org as a charity.
The world's first charity for myelopathy.
It looks like it at this point.
It's very exciting. Well, we hope it goes well, and we look forward to catching up with you in the future to hear more developments.
Thank you very much.
Thank you.